Thank you very much, Eric. And I want to thank Dexcom for having me here today to share my CGM clinical experience with all of you. Just to figure out the challenge that I'm facing, will you please raise your hand, those of you who are not yet prescribing CGM to your patients, please. Okay, maybe you don't understand me. How many of you are prescribing CGM to your patients? Okay, most of you. Okay, that makes my task easier. Okay, CGM technology has been around for a little bit more than 10 years for healthcare providers. And since those early days, the technology has improved a lot in both sensitivity and specificity. CGM has also been available for the last 5 years for an increasing number of type 1 diabetic patients. And up to 2010, an estimated 100,000 type 1 diabetic patients worldwide were owning a CGM device. Okay, this is my disclosures. I have research grants for both Novo Nordisk and Sanofi Aventis. That's it. And in today's talk, we will review some key basic concepts of CGM. Then we'll see benefits and challenges. Later, we'll move to the indications and practical tips. And finally, I will share with you my thoughts about the future of CGM. This is diabetes monitoring history. And we are all very lucky because right now we are witnessing the beginning of the third era in diabetes management. 2006 marked the beginning of this new era, because never before in the history of diabetes management has there been an option available to improve glucose control without increasing the risk of hypoglycemia. There are three main components in any CGM system: the sensor, the transmitter, and the receiver. And here you have the CGM devices approved by the FDA for professional use. We have two systems for professional use: the Dexcom 7 Plus, who can be blinded and so used as a professional CGM device, and the Medtronic iPro, who has a small recording device with minimal patient interaction. And then for patient use, we have three systems: the Dexcom 7, who can be used alone or in combination with the insulin vibe, available in some European countries, and the Medtronic Paradigm, who can also be used alone or with an insulin pump. The third system is the Abbott Navigator, who is no longer available in the US since August 31st, but it remains in the market in the other 7 countries where it has been marketed. I have to say that all the current CGM systems are approved only for adjunctive use and not for replacement for home glucose meters. Confirmatory finger sticks glucose measurements is required prior to change in therapy or taking action. There are some important issues about lag time that I want you to understand, and you have to make patients understand it too. First is that lag time is due to the fact that biologically, interstitial glucose lags behind blood glucose levels by 2 to 5 minutes. And the total time lag is obtained by the sum of a biological time lag plus instrument time lag. So it occurs with all the subcutaneous sensors, but it's different for each system. It delays alarms of hypoglycemia. In some cases, recovery from hypoglycemia may be delayed on the sensor and affects calibration of the sensor. Calibration teaches the sensor the correlation between current volume and the sensor glucose readings. And calibration don't have to be made during the stable glucose for all the sensors. Depending on the sensor, use the sensor trend data of a 1, 3, 6 hour graphs to ensure a good moment for calibration. And calibrate it routinely without waiting to be required by the device. Calibration, the minimal calibration is once every 12 hours, and you can calibrate where the glucose is high, low, or in target. During the 2008 ESD Congress in Rome, the GDRF CGM study group presented a landmark study that you all know. You remember that was the first time that has showed that A1C can be reduced when the sensor is used for more than 6 days a week. In all age groups, they get the same benefits. And the benefits were sustained after 1 year. I've got this funny slide for you. This is from my informal survey that, as you can see in the picture, when patients use it continuously, you can predict, in the majority of the cases, the lab A1C value just by downloading the data, despite the individual differences in glycosylation rates. Direction and speed, that's the key. That's the real advantage of the CGM. It's not important that sensors are not as accurate as blood glucose mirrors, as long as glucose monitors continue at the usual frequency. So why CGM is so needed? What is the diabetes' greatest diabetes nightmare? You probably agree with me that it's hypoglycemia. All the people with diabetes hate them. They don't want to have them. They're scared of them. And neither do their loved ones. So CGM can help. CGM, I think it's the answer. And what is the greatest diabetes enigma? Maybe it's where the glucose is hidden. And again, CGM is the answer. What are the best indications for the CGM system? Poor glycemic control or high glucose variability, despite the fact that some of those patients may have A1C at goal, and Dr. Debris will talk us more about the subject. Severe hypoglycemic episodes and awareness of hypoglycemia, or when hypoglycemia is a barrier to achieve optimal glycemic control. Pre-pregnancy planning or pregnancy. Improvement of quality of life. Intensive diabetes management in patients with type 1 living alone. Maybe you agree that otherwise it's contraindicated. Initiation of CSII therapy. Patients with severe gastroparesia. Severe insulin deficiency type 2 patients. And as an educational and empowerment tool for improving A1C for both type 1 and type 2 patients. So why we should use a CGM system? It can be used for prevention of low blood glucose, prevention of hyperglycemia, to have a better outcomes in diabetes pregnancies, as a behavior modification tool to measure your improvements daily, to live better and to feel in charge of your own body. The peace of mind is priceless, as you probably agree. To improve the quality of life of your family and your significant ones. And to prevent, probably, to prevent or diminish diabetes complications in the future. As we want to say, experience is the universal mother of sciences. And we have learned from the experience a lot of things. We have learned who is more likely to stick with a CGM system. Those who can cope with the frustration of calibration, sensor insertions, and alarms. Because even with the best technologies, bad days happen. Those using minute-to-minute data, also retrospective data analysis to correct their mistakes and learn from them. Those who can live with wearing a mechanical device. And those who have supported HCPs and are able to communicate their fears and concerns. There are some common reasons for frustration also with CGM. The most frequent is unrealistic expectations, because CGM is not a technology that can dose insulin, and CGM is not a cure and will not fix everything. It only provides information, lots of good information, but good judgment is still needed. Poor understanding of the lag time, alarm fatigue syndrome. We ask our patients to go back to basic alarms and set wider glucose range for a while, and sometimes it works. Those who lack continued ongoing diabetes education or medical follow-up, family involvement or emotional support is needed. In our experience, this is the secret for success. If you have a family who supports you, you will get with CGM. Those who have an over-obsessive nature, maybe CGM is not for them. The real world is quite different of the RCTs. As you show in the literature, all the RCTs have shown that the greater the use, the greater the benefits. But in the real world, most patients use CGM intermittently for different causes. Cost, excessive allergic problems, alarm fatigue syndrome, or family distress, or need of a diabetes vacation or diabetes break. Remember that diabetes is a 365-day-a-year condition. And as my friend Richard Rubin says, every leap year they get 1 extra day of diabetes. It's very important to look at your device. We ask the patient to look often, and they can learn a lot of things looking at the screens of the receivers. They can help fine-tuning the insulin regimen. They can review the effects of different food choices, check the effects of the activity level, understand how behavioral choices impact blood glucose levels, use the 1-3-hour screen for bolus corrections, and use the 12 and 24-hour screen for basal insulin adjustments. We ask our patients not to wear a watch, so hopefully they look more often to their CGMs. And we ask our patients to download the data every week, and I confess you that some patients do it. And probably with the next generation of the CGM, the downloading time will be shorter, and they will have one less excuse for don't do it. We have trend graphs where you can see several days or different times of the day. You have pie charts where you have percentage of time where the glucose is above or below a target, and compare different periods of times, and then you have the distribution of the glucose. In our clinic, we think that all type 1 are good candidates for CGM. But we do monthly classes for prospective candidates. We explain what the CGM system is, how it works, and what the different types of CGM systems are, advantages and disadvantages of the CGM. We invite patients to give testimonials. We offer a week of trial work for those patients interested before purchase it. And for the last 2 years, we offer this educational opportunity through the internet with Skype for those patients not able to come to clinic or who live very far away. Our initiation for CGM plan is a 4-week plan. On the first week, what we call observational or rookie period, we just teach the mechanics of the device, basic alarm training, identify blood glucose trends, start to interpret the glucose retrospective data, and week 2, the patient must learn to identify behavior changes, how and when to bolus with certain foods, and how to manage blood glucose swings during and after the exercise. The week 3 is a mail and phone contact, and the week 4 is the last visit, and then they get the certificate for the CGM user. We discussed with them the interpretation of the retrospective continuous glucose data, how to react to low and high alarms, how to react to trend alarms, becoming an arrow expert. Those who dominate the arrows are those who get the most from the CGM. We ask our patients to follow the trends and know the numbers. Finally, they must interact with the healthcare providers at least every 3 months continuously for success with the CGM in the long term. Of course, we tailor our programs for some special patients' needs. We ask our patients to avoid perfectionism, because as a famous painter Salvador Dalí said, have no fear of perfection. Anyway, you never will reach it. Okay, here you have some important websites where you can find more info about CGM. And my conclusions: thanks to the evolution of the CGM technologies, the stage is set for a revolutionary shift in diabetes care. Sensors are not as accurate as VG meters, but this limitation is compensated by the additional glucose dynamics information. Education regarding this technology and behavioral modification is extremely important. Patients need guidance of how to derive benefits for all the additional information without being overwhelmed by the amount of data. Some patients can improve A1C and reduce hypoglycemic episodes with the help of this technology, and both MDI and CCI patients get similar benefits. CGM adoption in diabetes care will depend on you, will depend on the development of CGM units for training and follow-up care of those patients. Like most of diabetes tech devices, success is difficult to show in traditional RCTs because so many factors are involved. CGM has landed in the diabetes field to stay. As you probably know, there are more than 100 companies going after invasive, non-invasive, and implantable sensor technology, CGM technology. And in my opinion, all these companies are not developing all this technology because it's fun and it's exciting. I think it is. But to improve the quality of life of the people with diabetes and probably to prevent diabetes complications in the future. And this is how I see the future. CGM will improve in accuracy, reproducibility, and predictability of hypoglycemia. And the software will be developed with better indices to measure glucose variability. Durable implantable sensors will be a reality. With proper reimbursement, it will become the standard of diabetes care for type 1 diabetes patients. And we have already 3 or 4 countries in Europe that they are starting to reimburse the CGM for their patients, like Sweden, Holland, and the Czech Republic, and Slovenia. I think Slovenia. A secure network will allow patients to make real-time adjustments and share treatment information with their HCPs, will ensure that CGM can flourish in a patient-driven system in spite of the challenging economic environment that we are going through. The development of the real closed-loop system will change the way we treat patients today. Probably will put most of us out of work or into early retirement. And now, this is no RCTs, this is real life. I want to commend you some patient testimonies. And the first 2 are in the original in Spanish. And I will try a slide for you, for those of you who don't speak Spanish. First one came from a rookie patient who just started 1st of September with the Dexcom. By chance, all these testimonies are using Dexcom, but it's only by chance. No, because this is the Symposium Dexcom. Say, I am very happy 2 days with the Dexcom. I am very happy with my Dexcom. Now I realize how many mistakes I did with my food and with my insulin in the past. We are all very happy. It means she and her family. And 4 days later, the second mail says, now with a few changes in my rapid insulin analogs, I can control the peaks after meals. We are all very happy, Ramiro. And as you predict, I'll soon will get down my A1C to 7. And the next came from one of our patients who wrote this in one of our blogs a couple of weeks ago. Said, my dream came true. When I finished the 300 kilometers in the Pilgrim's Way of Santiago in 16 days, like everyone else, with my severe hypoglycemic and awareness, I never could do this without my Dexcom. I ate while I walk if I need to. And I have only 2 miles hypoglycemia in the 16 days. Now, it's part of my life. It brings me peace of mind, but not only to me, but to my husband and son. And the next come from veterans, are more than 4 or 5, almost 5 years on Dexcom. First, it's Guillermo, say, it's really amazing. I'm wearing my CGM device for almost 5 years, and I'm continually learning new things about my diabetes, because every day is a different story. And the last came from Milagros, say, now I can see what is coming. It is the first time in my 31 years with diabetes that I can relax. Now I am in charge of my diabetes instead of the other way around. First, I want to thank 2 special friends of mine for helping me to fall in love with diabetes technology many years ago and becoming an advocate of the diabetes technology since then. Jay Schuyler introduced me to the insulin pump therapy in the mid-80s. And Dr. Earl Hirsch introduced me to the CGM technology in the late 90s. Thank you both. And my gratitude, admiration, and special thanks goes to, of course, all my patients who cope bravely with diabetes in their own unique ways. They constantly amaze me and teach me every single day. Thank you for your attention.
Thank you very much, Ramiro, for this very lively presentation. So, as you understand, it is real life with CGM. It's not clinical studies. Of course, they are needed, but what is very important is to understand what is how CGM is used by the patients in everyday life and also by physicians, healthcare team. And I'm sure that you will have several questions to ask to Ramiro about his practice compared to yours and how you could improve from this presentation.